So I'm really, really excited. We have a fantastic presenter on tonight. I'd like to tell you a little bit about her. Leslie Stevens has actually been involved in the world of pediatric sleep breathing and airway for over 35 years. She's the CEO and president of HealthyStart. Leslie is an international lecturer and trainer, and I really don't think that there's a question in the reference to the subject of pediatric sleep breathing, airway health, and HealthyStart's connection that she cannot answer. And really, when you have the backing of a company like HealthyStart by Ortho, you have over 51 years, you have over 4 million cases and tons of research to back you. Now, most importantly, she's the mother of 3, so her goal and desire is to provide every advantage for children to allow them to live healthy and happy lives. Now, as you'll learn tonight, there is a silent epidemic affecting 9 out of 10 children, and this epidemic manifests itself in a variety of symptoms that can easily be overlooked, misdiagnosed, and most unfortunately left untreated. So it's absolutely critical that children are evaluated for sleep and breathing habits. Leslie's mission is to educate both dental professionals and parents to ensure children a lifetime of health, happiness, and success. So I'd actually like to take this time to hand the floor and the mic over to Leslie Stevens.
Well, thank you so much, Susie. It is absolutely my pleasure to be here tonight, and I really look forward to a great presentation and maybe getting to know some of our doctors that are on tonight. I had the fortunate ability to travel to the IDS this, I guess, 2 weeks ago, and lectured twice over there, and really had a great opportunity to meet some really interesting doctors from all over the world. And I know a lot of them are here, so welcome. I'm glad you made it. Some of you, I know it's in the middle of the night, so congratulations. If you're watching this in the recorded version, shame on you, but I'm glad you got a good night's sleep. So anyways, tonight we're going to spend about 45 minutes to an hour talking about pediatric sleep, breathing, and airway, and the impact it makes on children, how we can evaluate it, identify it, and most importantly, treat it. So without any further ado, let's get started. Let's see what this is all about. As I said, this topic of pediatric sleep has really gained so much momentum. It's the #1 area in the United States, the topic of choice in almost any type of dental, orthodontic, or pediatric meeting. The ADA has, in fact, implemented a direction for the dentist that basically require them to evaluate each and every patient on sleep issues as well as improper growth and development. The orthodontic community has followed suit, and the pediatric will be in the next few months. Will probably come up with their policy. So this has gained so much momentum, and it's basically a part of what we do in dentistry. As a dentist, we realize that it is our responsibility to be able to provide the education for our parents to explain what is going on with their children, but then provide them with practical information and maybe even treatment options for their children, so that really no child goes either uninformed, but hopefully more likely untreated. So when we looked at sleep, breathing, and airway issues in children, we realize there are outward symptoms that make this topic a little bit more interesting and easier to identify, especially for parents. We know that research has shown 9 out of 10 children will have one or more of these outward symptoms. So in the United States alone, that would represent 40 million children. It's a huge number. I would call it an epidemic. I would call it a silent epidemic. I would say that majority of parents are uninformed, and hopefully after tonight, you will be part of the educators that go out into your community and are able to educate these parents to help identify these outward symptoms in their children so that they can be evaluated. And the evaluation that occurs for our dentist is basically looking at the underlying root causes that can create these deficiencies and cause these outward symptoms. So what are these outward symptoms? Well, they include mouth breathing, snoring, teeth grinding, swollen adenoids and tonsils, chronic allergies, eczema, asthma, ADD, ADHD, aggressive behavior, depression, irritability, anger, peer problems, few friends, bedwetting, difficulty in school, which is kind of interesting because it includes specifically the subjects of math, science, and reading. Also delayed or stunted growth, restless sleep, nightmares, morning headaches, daytime drowsiness, frequently waking up at night, sleep talks and walks. And there are other symptoms, outward symptoms, but these are probably the most prevalent that we will see. So currently, if a parent identifies one of these outward symptoms, typically a parent will look at it in isolation, meaning that they might take EDD and ADHD, and they'll see a specialist in order to have their child evaluated. And then that specialist might recommend a variety of different treatments. Most of the time we see a lot of drugs that are being prescribed for ADD and ADHD, but there are other things, psychiatric testing, counseling, therapy. We look at allergies, again, going to a specialist and prescribing maybe steroids or different medications for that. Asthma, same kind of thing. But what's really interesting is to realize and have a parent understand that many times these outward symptoms might be related to an underlying root cause. And that's what we're trying to identify in these kids, and to see what outward symptoms we can identify, but then more importantly, looking at the root cause so that we can identify these deficiencies. So often, as we just described, these outward symptoms are many times the symptoms are only being addressed and not the root cause. The treatments tend to be short-term Band-Aids. Many times they involve several drugs with many side effects. And unfortunately, it can be costly, painful, time-consuming, and most often ineffective. So we talk about the root causes. What exactly would we look at a child to understand and identify these root causes? Well, we're going to look at a few conditions, specifically mouth breathing, a narrow palate, improper tongue placement, and jaw relationships. So how do we screen for sleep? The first step is visual clues. And a parent can identify them. Unfortunately, sometimes with a parent, we see our child day in and day out. So many times it's hard for us to pinpoint these characteristics. But you as a dental professional will look at a child. I mean, even if you're on the street, you can see these children and identify certain markers that would give you clues that maybe there's other issues going on. For instance, the girl on the left, take a look at her circles under her eyes. We sometimes call that venous pooling. But look at where the position of her head is. It's lurched forward. She trying to get more air? Probably. This boy on the right, take a look again. Deep circles under his eyes. You can see the venous pooling. But take a look at how his mouth is set up. Lips are parted. We see a rolled lip. Tendency is probably a mouth breather. This boy tends to look a little heavy, almost like a double chin. Unfortunately, this child is not heavy, but the position and the deficiency in that lower third causes the appearance of almost a double chin. Take a look at the child's profile. Take a line and draw it from the forehead all the way down to the lower portion of that face. You can see the deficiency of that lower third, especially in the mandible area in this child. Look at the rolled lip. We already know it's probably an overjet. That lip is basically impacting the amount of development that occurs in the lower jaw, and it is conflicting, so it gives the appearance of an overjet. At the same time, with the lips parted, tendency is that probably will be a mouth breather. Take a look at the girl on the right. Again, draw that line, see where those deficiencies are. Sort of the same lip movement that we saw in the girl on the left, but take a look at how her chin blends into her neck. We call that a funnel look. We see the circles under her eyes. We can already know that there are probably sleep issues for this child. The second area that we use as a screening tool is a sleep and speech questionnaire. It's an excellent tool for you to use. It basically, the initial column means what conditions are present. We ask a parent to fill it out in regard to their child, and we kind of want to know a little bit about that child. So they will indicate the symptoms that are present in their child, but more importantly, they're going to also give us a severity. So from a scale from 0 to 5, 5 being the most pronounced, they're going to also identify but provide the severity. And if you look at question number 27, it is talking about the speech problems. So if there are speech problems present, we'll have them continue and fill out the rest of the questionnaire. Typically, we do see a lot of speech issues with these children, and we'll talk about the tongue placement, the lack of tongue strength, so the difficulty they have in pronunciation. So we'll talk a little bit further on that. But this gets us into a ballpark. It also helps a parent understand how some of these symptoms are linked together. Many times we hear a comment, bedwetting. What does bedwetting have to do with our dentist? Or what would bedwetting and ADD have in common? So these are great questions that parents will ask, and this begins the conversation. This is the point that education plays such a critical role, and you as their dental professionals are in an ideal position to provide some of those answers for them. This was a study that was done. It was in over 500 children, 501, and it basically looked at the sleep questionnaire and determined what were the most prevalent conditions, where there's some linkage, what was the average number. So the results that occurred was basically mouth breathing and snoring are commonly associated with more sleep disorder breathing symptoms than any other symptom studied. 9 out of 10 children had one or more symptoms of sleep disordered breathing. 60% of the sample had 4 or more symptoms. 1 out of 5 children experienced bedwetting. I want to make a note about that because that was kind of a shocker. Typically, we don't associate mouth or bedwetting with children that are older. Tendency is we kind of think it disappears. Well, it actually was present in 18.6% of the kids. So that means in a classroom of 20 kids, 4 of them will be bedwetters. So it's not something that we all advertise, but it's something to be aware of. So when you have patients in there, we have seen parents not indicated in the sleep questionnaire, but after starting a conversation and maybe talking in third person, that we do see a more frequent incidence of bedwetting. A parent will loosen up and maybe confide in you. It's important because the HealthyStart treatment is very effectual in the bedwetting situation, and we want to make sure we're tracking exactly the progress the child is making. This last point I will stress is a real critical one. Between the ages of 4 and 12, 92.6% of these outward symptoms do not self-correct, and 30% worsen with age. So what does that mean? It means if you see it, you should be treating it. If a parent indicates, well, you know what, let's see. Well, less than 8% will have a likelihood of self-correcting. That's not very good odds. And especially if we can provide a treatment that would be very effectual, it would be very permanent for that child because we're going to change not only the habits of the child, but the architecture, the foundation of the craniofacial development, and promote that growth and development, not only for today, but for the rest of their lives. So basically the treatment is very simple for them. Most of the kids just wear these appliances during the night. So these are things that are really important factors that a parent should weigh when determining whether or not they move forward with treatment. So again, I just want to emphasize the likelihood of cases not self-correcting. So here are some of the outward symptoms that we had a parent identify, and you can see that mouth breathing tends to be the highest. 43% of this sample basically demonstrated mouth breathing. And the question is, why is mouth breathing so critical? Well, one of the reasons is because by opening the mouth just by a half an inch, we actually reduce the airway by 6 millimeters. So what that means is a 7-year-old could have, typically has an airway of about 7 millimeters. Well, if we mouth breathe at night, we can actually close up, almost like taking a garden hose and kinking it and leaving that child with 1 millimeter of airway space. What is that like? That's like breathing through a coffee stirrer. Difficult. Are we getting enough oxygen? More than likely not. What requires oxygen when we sleep? Well, REM sleep requires oxygen. So do these children that have reduced oxygen, are they able to experience REM sleep? Typically the answer is no. It requires enough oxygen to get into REM sleep. And if there's any type of deficiency, that is going to be very unlikely. So that's why it's so critical. We want to make sure that child is nasal breathing. We want to make sure that the tongue is in the right position to make sure that occurs. But we'll talk a little bit more about that as we go through this evening. We also find that children who mouth breathe will typically exhibit 8 other outward symptoms. And some of these outward symptoms include snoring, difficulty listening and often interrupts, talks while sleeping, allergic symptoms, fidgets with hands, restless sleep, teeth grinding, feels sleepy and irritable during the day. So if you have a child, you probably know somebody. Typically when we give these presentations, each and every one of us knows one of those types of children that struggle with this. So if you're thinking about them, kind of go over in your head if you see a lot of these. If you see mouth breathing, if you see mouth breathing during the day, I can guarantee they mouth breathe at night. If you've heard them snore, or if you know they grind their teeth, maybe you've seen some of the wear and tear on the teeth. These are just some of the things to kind of keep in mind when you're thinking about these particular children. So what were the implications of this study? Well, the findings showed that sleep disorder breathing is much more common and affects children even as young as 2 years of age. There have been recent studies that even show children exhibit sleep issues even before they're born. Think about it. If a mom struggles and snores and has sleep issues, obviously that lack of oxygen is going to impact the fetus. So we do see some of these characteristics in unborn children as well. Begin treatment as early as possible to ensure permanent changes. Identifying outward symptoms displayed in 90% of the children that enter your practice can significantly reduce this epidemic and enable you to successfully treat the overall health of your patients. So let's talk about airway. Why is airway so important, and why addressing the habitual issues help with the airway? Remember, we talked about mouth breathing. Mouth breathing at night basically can reduce an airway by 6 millimeters. So we talked about the garden hose, which is the ideal for an airway, and the coffee stirrer, or the ability to, when we mouth breathe, basically kink the garden hose and reduce that airway down to 1 millimeter. I don't know if you've ever tried to breathe through one of these coffee stirrers, but I try everything. I try the appliances. I want to know exactly how they feel. We have very lengthy discussions with our patients about comfort and what it is and why it is, and they're always so shocked that I know every detail and how it feels. But I decided that one day I was going to try to spend the entire day breathing through a coffee stirrer. I wanted to see what these kids were experiencing when they were sleeping. And so I lasted about 10 minutes, and I have to tell you, I had the most massive headache I've ever had. I tried Excedrin, I tried everything. The only thing that basically cured it was by going to sleep and waking up the next morning. And my thought was, wow, can you imagine a child that mouth breathes every night and has that effect on their airway that basically reduces it to 1 millimeter, waking up with a massive headache, spending the whole day being expected to behave, to focus, to do their work in school, and I have no opportunity to alleviate that pain, go to sleep that night, recreate that whole situation, and wake up with a headache the next day. They have no relief. So it was a really eye-opening experience just to kind of put myself in their shoes and figure out what that feels like. So if you have an opportunity, you have a day to waste, go ahead, breathe through a coffee stirrer for the day. They do sell them at Starbucks still. I'm waiting for those to be taken off the market. I believe they have quite a bit of plastic in them. Anyway, so why is this epidemic happening? Why are we seeing so many kids having these issues? Well, it kind of goes back to industrialization and the changes that we have in our lifestyle. So tendency is we see children that basically have a lack of breastfeeding. Let's face it, both parents are usually working. It's difficult. I mean, if you have 6 weeks off at the beginning, that's great. But it's rare that we talk to parents or mothers that have had the ability to breastfeed for 2 years. So what do? We substitute. Obviously, breast milk can be put in bottles. The problem is the bottles have these nipples that basically depress the tongue. They also create suction in the mouth, so it narrows the arches. So now we have narrowed arches, the tongue is depressed, the nipple bottle has depressed that tongue low, so we don't have the opportunity to train the tongue. So where's the tongue supposed to be? Well, when we say the letter N, where that sound ends should be where your tongue should be at rest. Well, the nipple bottle, the pacifier, these are all elements that depress the tongue. Even a child's thumb depresses the tongue. And when it does that, it creates a suction as well in the mouth that basically constricts the arches. So basically the whole apparatus, the whole foundation of how this breathing ability should be developing is compromised. Another area that has caused is the soft diet. Here in this example, you can see the graduate puffs, the nutritious stack that melts in a baby's mouth. How often have you heard a child say, "Can you give me the toughest piece of meat? I really want to chew on that for a while." Well, back in the day, we used to chew on more rigid foods or a harder diet, and it helped expand the arches. It helped the development of the oral cavity. We don't have those same stimulus that we had back in the day. So we're seeing deficiencies occurring. Another interesting statistics is we know in this generation, 92% of the kids will have malocclusion. I mean, it is an epidemic. The amount and the lack of growth that is occurring in the oral cavity is kind of astounding. And realizing that we do have the ability to promote and to almost recreate what nature has done. And HealthyStart has been able to help do that. So we'll talk a little bit more about that. So what for you can you identify? Obviously a child's not going to come in typically with a bottle in their mouth or a pacifier or sucking their thumb, but we know there are certain orthodontic conditions that we can identify, that we understand there's a habit that's basically conducive to creating these kind of poor oral configurations. So for instance, if we see an open bite, we obviously probably assume mouth breather, probably assume tongue thruster, probably caused by either a bottle, a pacifier, a thumb, a finger. These are all things, but the important property here is we know that there's a mouth breathing situation going on. We will already know that, remember, if we have mouth breathing, we would tend to see 8 other outward symptoms. So as we look at this child, we're going to realize the deficiencies that are occurring in that oral cavity so that we can address them with a treatment that's going to address all of those conditions. The airway, kind of important, understanding where the nasal cavity is, where the hard and soft palate meet, the tongue, the airway. These are all different characteristics, kind of important to show a parent. So often we talk about mouth breathing, but we really should also introduce the importance of the nose. Why is that important? Well, the nose has basically 5 functions. It serves as an air passageway. It warms and moistens inhaled air. Its membrane traps dust, pollen, and other foreign material. Contains receptors which sort out odors, and it aids in pronunciation and the quality of the voice. How often do we see children in car seats? Sleepy, mouth open. Again, mouth breathing in our sample represented about 43%. I actually think it probably is higher than that, but obviously, you know, it's a significant problem. So I want you to take a listen to this. This is an interesting video. I want you to see how many times Eli stops breathing. I want you to see what happens when the mom can redirect where that oral cavity and where that placement of the mouth is. And I want you to look at his facial expressions from before and after. You're going to be shocked when you see this. And anyways, I'm going to play it and take a listen because it is that aha moment you're going to have.
Now he's holding it. That was holding it. He's still holding it. He's trying to take in air. There he goes. Okay, now watch. He's holding it. He's holding it. He's holding it. He's holding it. Still holding his breath, and now he's going to gulp again. There he goes. That was it again. And again. He's holding. He's holding. Right. There he goes. This has been 3 minutes and 15 seconds, and you can see how many episodes he's had of not getting calm breaths in. Now, watch what happens when I take his jaw and I just bring it forward. If I can. Let's see if I can. I hope that's the airway. Bring the airway forward. Got his airway, I'm moving his airway, pulling his jaw forward ever so slightly. And now he's breathing through his nose quietly. His mouth is a little open, but he's breathing through his nose. This way. Here, if he's breathing, you don't hear him anymore. And all I did is gently bring his jaw forward.
Pretty interesting. So we're going to talk about how we're addressing improper breathing, airway issues, lack of growth and development. But you can see simply if we can basically open up that airway, prevent that lower chin from drifting back, eliminating the mouth breathing, we're going to make a tremendous difference in that child and allow them to get the restful sleep, the REM sleep that's necessary. So when we talk about airway, there are a couple different factors that play into the airway and what a child has the capability of breathing at night or even during the day. So on the left-hand side, these are two different 5-year-olds. The 5-year-old on the left obviously has a constricted airway. Please realize these are cephalometrics. They are done in a vertical position. This is the best of all scenarios. We all know that when we go into rest and we're in a horizontal position, the muscles relax even greater and the tendency for the airway to collapse is higher. So obviously our tools are only good as our tools, and we have to realize that that is one of the drawbacks of both a cephalometric as well as a CBCT scan. So let's take a look at the child on the right. Well, great. Look at how great that airway is. It almost looks like a garden hose. So about 21% of the population will have a constricted airway in a vertical position. So that tendency is, so you know the percentages. So we talked about the effects of mouth breathing and what that does on the airway. So you could have a child that you took a cephalometric on and you see, wow, great airway, awesome, they should be fine. You take a look at the sleep questionnaire and it's a disaster. What is going on? We'll realize that this child probably has more of a habitual issue than a skeletal issue. And the habitual issue is probably a mouth breathing because, again, remember, when we open our mouth by 1/2 inch, we can basically close the airway by 6 millimeters. And you can see this is the same child, how that airway is constricted. What's the diameter? How do you explain to a parent how small an airway is? Well, what's interesting, in a 7-year-old, typically we'll look at the tip of their pinky, and that kind of indicates the ideal airway for a 7-year-old. Now, as we talked about the mouth breathing, we can eliminate 6 millimeters of that airway and bring that child down to basically 1 millimeter. And that's what that looks like. Look how small that is. A parent won't forget that. That's significant. So this is a great diagram as well to utilize during that conversation. This is an extremely interesting case. There is a way that we identify and basically give a millimeter average for a child based on their age. So typically starting at age 5, we can take the age of a patient. So let's say we have a 9-year-old. We would say 9 times 10. We would anticipate the airway to be a 90 square millimeter airway. As a child grows at age 17, we almost peak. We anticipate an adult's airway to be between 150 and 170 square millimeters. Bad news, at age 21, our airway will start to deteriorate. So it has always been a question. You might have an adult that has sleep apnea and they have a restricted airway. Now the question was, did they reach their potential at age 17? Maybe they didn't and the deterioration has occurred. Or they reached their potential of 150 to 170, but maybe that's not enough to sustain them for the rest of their life. So let's take this example. So here is a patient, actually a 9-year-old. We anticipate his airway to be his age. 9 times 10 equals 90 square millimeters. Well, obviously compromised, 53.6 square millimeters. So the patient was given a habit corrector, the first appliance in the HealthyStart system, wore it for 1 month, and we wanted to see what kind of progress that patient is making. So a second CBCT scan was taken, and look at this measurement, 337 square millimeters. Now, that's 6 times greater than what his initial was. But more importantly, what is that for an adult? That's almost double what we would anticipate seeing in an adult's airway. Now, do you think someone who starts with 337 square millimeters for an airway is going to be able to sustain a healthy lifestyle for the rest of their life? Absolutely. So these are the numbers, and this is the research that we are currently conducting to not only see what we can increase within the treatment of these kids, but also to look at the longevity of what has been treated. So there's a lot of exciting research on the forefront, and this is just the beginning of what we're talking about. Here's a little bit more about what we just described. So kind of let's recap what we have talked about. So we talked about mouth breathing and snoring and how these are critical habits that need to be addressed, because typically we see them due to extended bottle feeding or pacifier use, typically caused by poor tongue position and abnormal swallowing. Sugar and processed foods can be have an effect. Poor oral habits such as thumb, finger, lip sucking, tongue thrusting all contribute. So mouth breathing will then typically move into a compromised airway. And a compromised airway will reduce airway, restrict airflow, reduce oxygen, increase CO2, affects the brain function, immune and endocrine systems, creates swollen adenoids and tonsils, creates a low tongue position, tongue thrust, creates underdeveloped dental arches such as overjet, open bite, cross bite. And a compromised airway leads to sleep disorder breathing. And again, the symptoms that relate back, or the outward symptoms of sleep disorder breathing, can include restless sleep, ADD, ADHD, bedwetting, chronic allergies, nightmares, daytime drowsiness, aggression, difficulty in school, frequent infections. So you can see kind of the circular effect that occurs with these symptoms. So here's an interesting study that basically showed the effect of lack of sleep on the brain function. So the first three images are an MRI of an individual that had normal sleep. And you can see the brain activity by the yellow and the red color indications. And the last three MRIs are basically the brain function with 1 night of sleep deprivation. And it is really hard to see any brain activity. Here's a little spot here. So you can see the detrimental effects that occurs with a reduction in sleep just in 1 night. So let's talk about HealthyStart. What can we do? So HealthyStart is manufactured by a company called Orthotane, which has been around for over 51 years. We have treated 4 million children worldwide. We pride ourselves on being probably one of the forefronts in pediatric growth and development, and understanding how growth and development plays into the health and well-being of a child. The treatment basically are a system of appliances that are used to aid and help in the development of the oral cavity. So, for instance, if you have a child who is 5 years of age, they would fall into what we call the HealthyStart Kids system, which basically treats children from the ages of 4 to 5. The first appliance is driven on habits. It's all age appropriate as well. And basically it will help promote the proper habits and basically correct or eliminate the improper habits, including mouth breathing, transitioning them into a nasal breather. Once the first permanent tooth starts to come in, we'll move into the second appliance, which will actually start guiding the incoming dentition, expanding the arches, correcting any overbite, overjet, open bite, gummy smile, class 3, cross bites, the way nature. So it is promoting the growth and development, allowing the dentition, expanding the arches, and allowing the dentition to come in correctly. And the third appliance is basically following, again, the growth and development. As the laterals erupt, that child becomes a mixed dentition. So the third and final appliance will be in that position, again, still guiding the teeth in and correcting the functional problems, as well as promoting the growth and development of that case. Obviously, our youngest patient is about 13 months old. Our oldest patient is about 84. We typically talk a lot about growth and development in the pediatric patient because we can make more permanent changes. When we're looking at an adult who's 40 years of age, 40 years is a long time to have a habit, and it makes it more complicated to change that habit. There also is no more growth and development. So we have to make sure how we're stabilizing that case and what is the long-term stability for that case. So we can talk about that. We do a great job addressing these. I always look at it, I would love for someone to be able to go through the treatment, toss everything away, and enjoy a lifetime of stability. With a 40-year-old, I'm not sure if that happens. Tendency is we see maybe about 50% of the cases, and the other cases will have to wear something every night. So those are kind of the guidelines, and those are the restrictions. So again, HealthyStart is going to address the root causes, and these root causes include expanding the dental arches, We can expand about 77% of the expansion that we need. The greatest amount of expansion, if we catch the child at the absolute ideal time, is about 6.7 millimeters. So we do a significant job. Can we correct every expansion case? No. But we can use adjuncts to help us with that if we have a very severe case. So we're very proficient in how we utilize the system, and we're not afraid to add adjuncts to it if we need to in order to expand the amount of kids that we can treat. The HealthyStart will establish nasal breathing. It will train the tongue. It will eliminate bad habits. It will advance the mandible to correct overjet. It will encourage proper facial and body growth. It will correct most orthodontic problems. Many times we say it's like frosting on the cake. We do consider health issues our number one concern. When we look at orthodontic conditions, we can look at them in two ways, or maybe we should look at them both ways. Obviously, we want a beautiful smile, absolutely. But orthodontic problems relate to more health issues that are occurring. So for instance, if you see crowded teeth, obviously we want to straighten them, but more importantly, we should say, okay, why do we think there's crowded teeth? I bet there's a narrow arch. If there's a narrow arch, do you think the tongue is in the right position? Probably not. It's probably laying low. If it's laying low, I bet they're a mouth breather. If they're a mouth breather, I'm going to see 8 other outward symptoms. So that's kind of the thought process we're hoping that you're starting to see, and that you're going to look at children a little bit differently when they come into your office. So let's talk about the system and what we have to offer. As I said, the first appliance that we use in the HealthyStart system is the habit corrector. And this is a great initial appliance. It has myofunctional therapy built into every one of these appliances. So what does that mean? That means I'm actually, just by the action of a swallow, I'm going to create the myofunctional therapy that's going to allow a child through repetition to learn the proper way to swallow. I'm going to teach them the proper place where that tongue should be at rest. I'm going to eliminate that mouth breathing and create that nasal breathing. I'm going to start expanding those arches so that I'm creating the parking spot for that tongue. I'm going to prevent that lower chin from drifting back. So I'm going to keep that airway open at night. These are just some of the things. So if you look at the appliance, you can see the features that create this. So up on top, you can see what we call palatal tabs. So the tongue is actually going to be pressed against these vertical tabs and start the expansion. Create that parking spot for the tongue. We're also going to see these little prongs here. So, and there's a ramp, we call the lingual tab. So as the child swallows, the tongue lifts, it goes up the ramp. The prongs prevent it from being a tongue thrust, but also indicates when that tongue should come back. It's going to position it correctly. So it's going to repeat that pattern 500 times every time they sleep. So at night, we swallow 1 time a minute at night, 2 times a minute during the day. So just by wearing it at night, it's about 500 repetitions. We also see that we have little tabs that prevent the lower chin from drifting back. We also have posterior pads. If there's an open bite, we'll close the open bite more quickly. We have a pull tab that will make it easy to hook onto night clothes at night. We also use it to help see how much lip strength that patient has. These are all great features. And what makes it so great is that it's activated by a swallow. I mean, there's nothing easier. And it's ingenious because I'm sure you've heard of myofunctional therapy, and it's wonderful. Oh my gosh, exercises that help develop the oral cavity. But the problem is the cooperation. How much cooperation do we get from our kids? And kids are great. But if I told them, I want you to do this 200 times a day, I know, I have 3 kids. I can already tell you, they probably would do it 5 times. And not because they're bad kids, but they would say, oh, Mom, I think I probably did it 1,000 times. Well, they don't have that capability to know repetition or have that ability to count how many times they did it. And it's hard. I mean, parents, we come home at night, we have so much to get accomplished before they make it to bed that it's one more thing on that list. And so the studies, most recent studies, shown that I know there was a study of 90 kids, and out of the 90 kids, only 2 of them did their exercises. And they compared it to an oral appliance. Well, the oral appliance that we have that is unique to HealthyStart, that was developed by HealthyStart, basically puts that whole concept into a mechanism that's easy for a kid to accomplish, easy for a family to incorporate within their routine. So it's tremendous. And the changes that we see are incredibly significant. So we talked a little bit about tongue placement and the importance of where the tongue is, but also proper swallowing. So how do we determine how our child swallows? Well, an easy way is take a glass of water and watch your child swallow that water. Typically, when we swallow and take a sip, we should only see these muscles moving. However, if our child takes a sip of water through a glass and all of a sudden we see they're using that tongue to try to get that swallow, and that tongue is in the improper position. So as we go through treatment, we'll continue watching your child swallow just with a glass of water and see that the muscles that they used to use will diminish, and all we'll see is the movement in the neck. So it's really kind of an interesting concept, because obviously hard to get into that mouth when they're swallowing to see what the tongue is doing. But there are outward symptoms, again, that we can identify and understand the position of the tongue and position of the swallow. As we talked about before, how many times we swallow during the day and at night, easy to remember, one swallow per night, 2 swallows during the day. Here's another interesting study, and it was done on 220 patients, and it was looking at the HealthyStart's habit corrector and how much correction we tend to see in these outward symptoms within the first 5.5 months. So let's take the first one, headaches. So headaches, we saw basically in the sample size, 18% had headaches. Remember I told you about trying to breathe through a coffee stir and having that massive headaches? It's interesting. Kids tend to not have the ability to communicate a headache. A lot of them have had it for so long, they just think that's normal. And, it becomes a more difficult conversation. Anyways, within this sample, that represented 40 children. Over the 5.5 months, we received 98% of the cases having improvement. The mean correction was 94%. The mean correction of the entire sample was 91%. 85% of the cases with 100% correction. So that's really substantial. You can see snoring, labored breathing, interrupting, and these are the symptoms that we see on that sleep questionnaire, and you can see the percentages. We did this so that within the first 5.5 months, you kind of have an understanding of what you would anticipate seeing a child correct. We are also conducting a study where we are doing it on real time. So we have an app that's available, and we'll talk a little bit about that, but we're able to have parents help us identify the changes as they're occurring on a day-to-day basis. So our desire is that we'll tell you within the first 2 weeks, you should see X, Y, and Z correcting. Within the 3rd week, we should see X, Y. So you kind of have a template. So if you're not seeing this, we really want to know about it so that we can help assess that child and maybe see if there's anything else that's going on. This is a fascinating topic, ADD and ADHD. All right, we all know. In my life, I feel like almost every child is being diagnosed for ADD and ADHD. Seems like a runaway train, an epidemic. Well, what's really interesting is the criteria that we use to diagnose ADD and ADHD is the same criteria we use to diagnose sleep disorder breathing. Now, it would be really simple if it was a blood test, but it's not a blood test. It's based on a list of criteria. So can these 2 symptoms be misdiagnosed? Absolutely. Currently, they say 85% of the children with ADD and ADHD have sleep disorder breathing. That's a huge percentage. So what can we do? Well, I think if a child is suspicious or suspect of having ADD and ADHD, maybe the wise choice is have the sleep evaluated first. It's easier to identify. It obviously can be addressed and possibly corrected in a more permanent fashion. And maybe that is what's going on rather than an ADD and ADHD. Or maybe it is ADD and ADHD, but it's being accelerated because of the sleep issues. So anyways, there's been probably many studies, but the most significant study was probably done by a woman by the name of Karen Bonnick. She actually watched over 13,000 children, and she found that sleep disorder breathing increases the risk of ADD and ADHD by at least 50%. ADD and ADHD patients have little or no REM sleep, but have delta sleep. Patients without ADD and ADHD have primarily REM and delta sleep. In the study that we did of 501 children, we found that ADD and ADHD were present in 25.2% of the cases. Here are some concerning statistics. So long-term effects of ADD and ADHD. 50% of children are held back 1 grade, 30% are held back 2 grades. Well, I've got news for you. If it's a sleep issue, you can hold them back 10 grades. It's not going to make a difference. They're going to have the same symptoms. They're going to have the same lack of ability to focus. They're going to be tired. They're going to be irritable. That is what we basically anticipate and identify with these sleep kids. The other issue is when a child is experiencing sleep disorder breathing, we find that the children have 10 to 20 fewer IQ points. Now, in my world, I think, oh my gosh, college or no college. Well, this study went one step further and actually put a dollar value on each IQ point, which is $170,000 per IQ point for the lifetime of a child. Another important statistic to convey to a parent when they're making that decision about treatment. So how does HealthyStart promote growth and development? Well, as we know, craniofacial growth occurs early on. We find, and our treatment protocol is basically we try to treat the child before age 12, before most of the craniofacial growth has completed. So at age 12 years, we find that 89% of males have completed their growth and 94% of females. So you can see the importance of early. You can see the trajectory of the growth of the craniofacial, which is forward and down. Tendency is we want to promote a forward growth using the HealthyStart system. So here's a case here, a HealthyStart case. You can see before and after. Take a look at the amount of forward growth that occurred. And this is only wearing an appliance at night. This started out at a child at age 5. She wore it for a little bit longer than a year and a half, and she experienced 54% more mandibular growth than in a control sample. We actually did one of the largest orthodontic studies, and we found that the study basically produced 54% more lower jaw growth than the control sample. So it was a very interesting study. If you go on our website, the study's there. If you need us to send it to you, we'll be more than happy. They did a similar study with Tufts University and same kind of percentage. Both studies were published in different orthodontic journals and pediatric journals. So you're more than welcome to take a look at it and to review that literature. Another interesting appliance that we use in conjunction is what we call our HealthyStart Max A corrector. You will see a lack of growth in a lot of these kids in the lower third. And many times it's the mandible, but now we tend to see even a deficiency in both the upper and lower jaw. So this appliance is very unique where there is no frontal wall. And there are tabs that actually we push the tongue against in order to move that upper arch in a forward direction. And the appliance is designed so the lower arch will follow in suit. So we're able to make a forward growth of that lower third. So you can see an example here. Here's initial, here's 1 month, and here's current. So you can see how that growth is being promoted. Kind of a similar situation with the class 3. Obviously, a class 3 is where the upper arch is being impacted by the lower arch. So the ability to have that upper arch grow is diminished because of that blockage. So same kind of appliance where there is no frontal wall. We use tabs to basically move that upper arch and make that jump for that patient. What is unique is both of these appliances take a very short time. The tongue is our most powerful muscle, so we're going to utilize it. So we make these corrections in 2 to 4 months period of time. So it is really, really quick. So here's another case that happened with, using the class 3 appliance. And let's make a point. There is a pseudo class 3 and there's skeletal class 3. This one is a pseudo class 3. Pseudos are obviously much easier. How you can tell if it's a pseudo is when the child bites down, if they bite end to end, and then they shift into a class 3. If it's skeletal, tendency is they bite right directly into a class 3. If you feel it's a skeletal, this appliance can still assist, but we're going to minimize the class 3 tendency in a skeletal class 3 patient. Treatment planning. We do help with treatment planning. The treatment planning is a great form to basically get the overall conditions of the case and help make assessments in where the child is and where they need to go. So here's the fun. Let's look at some cases now and go through them. So here's a 7-year-old boy. Obviously, the initial shows quite a lot. I believe it's 17 outward symptoms. So that's a lot. And a lot of 4s, 5s, that's a severe case. Now, this patient was introduced, the first appliance was the habit corrector. They wore that for approximately, I think it's 3 months. And here is the follow-up on their sleep questionnaire. I mean, here's a 1. Most of them are 0s and 1. It's tremendous. Look at that change. Look at what that parent wrote in regard to the speech. Very delayed speech. Didn't say a word up till age 3 or 4. That's significant. So imagine the changes that have happened. Now let's take a look at him. Cute boy. Here he is, March 2015, the initial portion of his treatment. You can see the severe, look at the overbite, look at the squareness of the arch. You can see the circles under his eyes. He was asked to wear the first appliance. That's how we started, and just wear it at night. So here he is in March 2015, July of 2016. So take a look. Look at the correction of the overbite. Look at the roundness of the arches. Do you think that tongue has a place to stay? Look at his facial changes. So dramatic. Now let's see how he continues. Beautiful. And he's a healthy kid. Here's another case. Again, you can take a look at the initial where we have the sleep questionnaire. You can see some 5s, 3s, 2s, 4s, and 3 months later, almost all 0s. You can see the deep overbite. Here he is in the progress. This isn't the finished case yet, but you can see where he's heading to, and we'll watch for his stability. Here's another case. Here's the initial, final, from beginning to end. Here's another case. You can see deep overbite. You can see the appliance in. You can see how the incoming teeth are coming in, rotated. The appliance will capture those teeth and guide them into the right position. It will all use the eruption of the teeth to expand the arches. During the transition from primary to permanent, we should see 4 millimeters of expansion. You can see how the teeth are then aligned and the bite is corrected, and we basically have a 3-dimensional type of treatment. Here's another before and after. Another before and after. This is an interesting case. This particular girl, her mom, I think she was 37, had all the tendencies that her daughter had no treatment, ended up with surgery later in her life. Obviously, she recognized the same symptoms that she endured and wanted to do something different for her daughter. So you can see, look at the circles under her eyes, look at the rolled lips, look at the deep bite, significant square arches, significant sleep issues. So we're going to take you through the treatment. It's going to basically encompass about 15 years. So here's her first, here she is, almost looks like a different kid. Look at the changes in the facial. Look at the overbite has been corrected. Look at the arches are rounded, the profile. So now let's see the stability of the case. Here she is. Continued. So you can see how beautiful that case remains and continues to remain. Here's another case, snored, brucks, bad breath, air infections. 1 year later. Here's another child, again, outward symptoms. You can see the corrections that occur within, I believe, 3 months. It's usually 2 to 3 months. We do a follow-up. You can see the initial, you can see the progress, you can see the square arches, and you can see how it's rounded. Here's another child, spectrum, snored, brucks. Mid-treatment, final, 14 years later. Nice, stable. I'll talk briefly about the app. We have a great mechanism to help with cooperation. We also have compliance, so we can manage, record, document, and obviously see the changes in our patients. So we will ask every parent, they will download this. It can go on an iPhone, it can go on an iPad. A child every day will wake up, the app will ask them, did you wear it last night? Did it stay in all night? They are rewarded with a coin they can deposit in the bank for future purchases. They get 30 minutes of game time that they can do. Every Friday, we will do a selfie. We do have cheek retractors. It lines up on the phone or the iPad. They'll create actually a flip book that will show the changes that occurred in their dentition. We will ask the parent on a daily basis, have you noticed any changes from their original sleep questionnaire? They can enter those in. All of that information is always available for a parent to show other parents, their neighbors, their relatives. But also what's really interesting is all that information is also put into the portal for your view. So when your patient comes in at their next appointment, you're able to evaluate the progress they've made during the 30 days, 60 days that they haven't been in your office. So it's a great tool for motivation. It's a great tool to monitor your patients. Parents love it. It's a great advertiser, not only for your practice, but also for the success of the patient that you're treating. Here's a little bit about what the cheek retractor looked like. So anyways, we've treated, again, 4 million cases. Please realize that our appliances are FDA cleared. There's no latex. Appliances are BPA, BPS, phthalate-free, no silicone. We regulate ourselves to a Class 2 medical device. Everything is USA made. We take great pride in the product that we deliver. Safety is our utmost concern, and obviously the well-being of your child. I'm going to leave it here. I'm going to have Susie describe a little bit about our digital class and how we can utilize that, how we can educate you. This was such a small tidbit. I probably ran a little bit late because there's so much to go over, but the digital is a wonderful tool. So Susie, I don't know if there's any questions tonight, or if you want to basically take a few minutes and go over the digital class.
Yeah, I would absolutely love to. As of right now, there's not any questions that have come in, but keep in mind, doctors, I know that this is a lot of information, so use that Q&A if you have any questions, and we'll be happy to answer them after. But yeah, I would like to tell you a little bit about our digital education platform, probably the most popular platform. We've had such amazing response from our digital course. It's great because we can actually train doctors from all over the world, which is fantastic. It's a 6-session digital education series. What I love about it is that it's comprehensive, meaning that it actually includes you and all of your staff members. And I love that because this is something that you really want to make sure that you have your staff on board. You know, they need to understand what you're doing, you know, how you're working with these kids now. And so this course actually includes everybody in your office. So it actually comes with a hands-on treatment of 2 full cases. So, you know, the education is so important, and you're going to hear from the experts on how to assess these kids. But we also want you to learn hands-on as well. So we're going to actually give you 2 entire systems so that you can work with 2 children in 2 different age groups from start to finish. And that includes their suggested treatment plan, all the appliances that those 2 children need, specialty appliance cases to, you know, so they can put their appliances in. And that HealthyStart mobile app that Leslie was talking about, that actually comes with your case as well, which is such a fantastic way to learn. So we kind of take you from start to finish with these 2 kids and handhold you through it. This course actually complements the ADA policy on sleep-related breathing disorders. And you know what this policy says, of course, is that every dental professional should be assessing kids for sleep and breathing issues. And this gives you the ability to do that. And it actually complements that policy. It actually comes with a $3,000 voucher to also attend a destination course. So, you know, the digital course is fantastic. It's, like I said, it's 6 sessions. And the way that it works is on a Monday morning, we actually email you out a series. The series is about an hour and a half to 2 hours long. So it's not too long, but you have the entire week to watch it. So you watch that series, write down any questions that you have. And then on Friday, for the 6th series, we have a live interactive study club. The study club is great. We actually go over the highlights of the series that you had the week to watch, but we also bring on a specialist every week to talk about different things, like, for example, billing, or how to integrate HealthyStart in your office. Even things like, you know, how to talk to the parent, you know, how to bring up the subject, the things that your hygienist should look out for in these kids so that way they can convert them into a HealthyStart appointment. So it's a pretty comprehensive course. You're actually going to receive a sample acrylic stand as well. The acrylic stand is great because it comes with sample appliances. Again, when the parents are coming in and they see the appliances, it brings up the question. You have the ability to show them how it works. So it's really a great comprehensive course. On top of that, you'll also receive training on pediatric treatment of sleep-related breathing disorders and how to identify it in your patients, how to use HealthyStart to increase your patient flow, which starts from the beginning. I mean, we actually will send you your starter appliances. So the habit correctors that Leslie was talking about, those are your starter appliances. And I'm positive that you already have kids in your mind that you know need these appliances, you know, to really start breaking those oral habits, start training that tongue to be in the proper position. You know, all of those things happen, as Leslie was saying, while the child sleeps and they're wearing the appliance. So you can get those 2 children started immediately. And so what happens is they start seeing changes in their kids. You know, they start, all of a sudden their kids, you know, some of these symptoms are relieved, and some of it is pretty fast. It's pretty immediate that these symptoms start going away because now they're breathing properly. They're receiving the proper oxygen into their system. And so they start talking to other parents, and next thing you know, you have these parents calling you wanting to know what you're doing. And we help with this as well. We do all kinds of different things to help educate parents. That's one of our missions, is to ensure that parents are educated. So, you know, we're about educating the doctors, but a huge part of our process is to educate the parent as well. I mentioned that the course includes all of your staff. You actually earn 18 CE PACE credits and then 16 more when you attend one of the destination courses. So a little bit about what doctors are saying about the HealthyStart digital education course. So we had a doctor from Australia who attended. He said the digital course was excellent. All at HealthyStart have really got their act together and offer resources others strive for but rarely achieve. Well organized, passionate, and supportive. Doctor from Canada. I want to thank you and your colleagues for this amazing course. I've been searching for a solid system to help my patients, and this is by far the best, most organized, comprehensive course I've taken. And Doctor from Colorado, I've really enjoyed the course. We've identified quite a few patients that will benefit from HealthyStart. My business partner's 4-year-old is in the habit corrector because he has had swallowing problems, and we've already seen great improvements in his eating. We already have 3 more patients ready to start next week. We can't wait to see the progress. I really love that particular testimony because Dr. Wright was actually in the 3rd week. So I mentioned it's a 6-week series. She was in the 3rd week and she already had patients calling her. And that's because, like I said, we're going to mail you rather those habit correctors immediately so you can start those 2 cases. I'm telling you, the word spreads. Parents get really excited when they see their children, their health improving. So American Dental Association actually took our course and they said it was ingenious. Which is high praise, I think, from the American Dental Association. So key financial metrics, startup cost analysis. So typically the cost for the course is $3,400 for the digital education course, and then $400 to attend the live lecture, which is fantastic due to the fact that it includes those 2 cases, all of your staff, and all that good stuff. A lot of you guys were at IDS with Leslie, and y'all stopped by the booth, and so we want to give you guys the opportunity to take advantage of the promotion that was offered. And so you can actually sign up for the course for $3,400 for the digital education course, and that will include the live lecture. So it's basically 2 courses for the price of 1 is what we're doing. And the course starts April the 1st. So this is actually perfect timing for you guys. I mean, this starts pretty quickly on next Monday, I believe. It's the 1st of April. I always say, don't wait. Now is the time. I mean, now that you get this, now that you understand that there's a problem, we have the solution. And that's one of the things that I love. We've been to a lot of airway summits. We've been to a lot of symposiums. And I think one of the things that every doctor who attends that I've talked to is, they realize now that there's a problem. They understand that these kids need help. The biggest question in their mind is, now what? And so we give you that solution. We actually give you the tools to act, to do something and to help these kids. And so you don't want to wait. So it's really, really simple to take advantage. And as I mentioned, register tonight. We'll send out FedEx your first set of habit correctors for your 2 free cases, and we'll teach you how to submit the rest of the case. We'll give you a portal, your own personal portal that you can keep all the information in and submit your cases electronically. We'll connect you to a forum online where you can talk to lots of other providers and share stories and photos and all that good stuff. So we'll get you all set up. So you can either visit openairwaydentistry.com. You'll see that there's quite a few of the register now buttons on there. Just click one of those buttons. It'll take you to the seminar enrollment form. Just fill out that form and that'll get you all set up, and that's that. And then we'll send you an email back to confirm, and then we'll actually ship out everything to you very quickly. Of course, like as I mentioned, the course starts on April the 1st. If you have any additional questions, sorry about that. If you have any additional questions, you can actually contact me directly as well, and you can reach me at slafredo@thehealthystart.com. If for anything at all, if you have a question about this, or if you just want to email and you'd rather sign up for the course, via email with me personally, that's totally fine as well. So whatever way works best for you, we will help you get set up. And as I mentioned, now's the time, and don't wait. And we'd absolutely love to have you as part of our team. I actually see that we have a couple of different questions, so I'm going to click on that really quickly and see what kind of questions you have rather. And Leslie, if you're still available, maybe you can pop back on and I can ask you some of these questions.
Sure.
Okay.
I'd love to.
Okay, awesome. Okay, so one of the questions is, will this work for a teen who is still thumb or finger sucking, or do you need to catch this earlier for it to work?
Well, as I said, if we work on someone that's older, obviously the habit's been more ingrained, and the ability to have growth and development has probably reduced to a limited amount. It's not to say it can't happen. It's just a little bit more difficult. I would absolutely give it a try. I tend, especially if I see a thumb sucker or a finger sucker, we usually will ask them, when do you typically have or start this habit? Typically I hear, when I'm tired, I'm going to bed, if I'm watching a movie. And let's face it, the child's putting their thumb in there sometimes to depress the tongue. Maybe they think it's helping them with their airway as well. There are instances, though, that thumb sucking might be more psychological. So just be a little bit cautious in when we address this, but absolutely give it a shot. It's not going to hurt the patient. I would say every time she felt compelled to put her thumb in her mouth, substitute the appliance. I always say use the word substitution. Don't say we're trying to eliminate a habit. We'll be more successful in that type. And we'll discuss this more in the digital. We talk a lot about little tools, helpful hints, guidelines, things we can do to help our patients. So absolutely, there's no reason why not to try. This success, though, might be compromised a little bit because of them being more advanced in age.
Yeah, awesome. Thank you. Okay, so the next question is, which is, I think we kind of talked about this already, but what is step one to start treating patients?
Step one, well, first of all, we need to go through the digital class. We really want you to have the expertise so that you know how we're going to address. When we look at a patient, the step one is basically we're going to do a visual assessment of that child as they walk into your office. Number two, we're going to use a screening device to be able to look at that child. Number three, you're going to do an evaluation of the underlying root causes. And number four, we're going to begin the treatment. So that kind of simplifies it, but basically you can kind of see the stages and the steps that we would basically participate in during the treatment with the HealthyStart.
Thank you so much. Great. And then Dr. Najjar, yeah, I can answer your question. Dr. Najjar is saying that he actually jumped on a little bit late. He's interested in registering for the digital education course, but would love to see a recording. So yes, absolutely. I have actually recorded this session, and I will be emailing that out so that way you can review the information. So yes, absolutely. So I want to, yeah, I don't see that there's any other questions. I want to say again, mention again to, just jump in, get your feet wet. The digital education is fantastic because we really do take you by the hand and, lead you and your staff through all of it. As Leslie said, so all of the questions that you, or some of the questions that you have, we actually cover pretty comprehensively, pretty extensively. So we really want to take you by the hand and lead you. And, as much as you want us to be involved, we are involved, from everything from promotion to marketing to helping you reach out to your community, letting the parents know what you're doing. I mean, we really, we take it seriously because it's really important to us. We feel as though every child, should have the opportunity to be a part, or if this is something that they need, we want to make sure parents know about it so that they can get the help that they need. So anyway, I'm excited. As you can tell, we're pretty passionate about it, and so I want to thank you guys for taking time to be on tonight. And Leslie, thank you so much for sharing this important information, and I wish you guys a great night. And if there's anything that you need, please email me or visit openairwaydentistry.com and get registered.
And Susie, there's CE credits. You'll send those out?
Yeah, absolutely. Yes, those will be emailed out within the next 24 to 48 hours. You'll receive your CE credit via email.
That's great. Well, I thank you all for taking time out of your night. I know there's basketball. I know there's a whole lot of things going on, but I will tell you, I know that sleep is currently the #1 topic in dentistry. I think it's going to be one of the biggest areas that ever came into our treatment protocol. You as a dentist, I always say, you're really an oral physician. So I am thrilled. I'm excited. The future looks ecstatic, and I just congratulate you. Please take a look at your patients tomorrow a little bit differently than you did yesterday, and let's start the education going. So thank you for joining us. I look forward to seeing you on the digital, and Susie, as always, thank you for your dedication and obviously all your efforts in making this always a wonderful experience. Take care, everyone.
Good night, everyone.
Bye-bye.